Good afternoon. Thank you for the introduction, Cecilia. As Cecilia said, my name is Elisabeth, and I work as an endocrine nurse in the University Hospital of Ghent. And Ghent is a very lovely, beautiful, ancient city in the west of Flanders in our small country, Belgium. So I'm very honored to give a presentation at the EC today. Thank you, Sophia. And my presentation is about the home care educational program for patients with acromegaly. First, I will shortly discuss the diagnosis and treatment of acromegaly. Then I will tell you all about the start of the home care program. Afterwards, we will have a look at the results of the observational study. And then at the end, I will tell you a patient story. So, as you all know, acromegaly is a hormonal disorder. So the pituitary gland produces too much growth hormone during adulthood. So the excess growth hormone comes from benign tumors called adenomas. And the pituitary gland produces several hormones, and the one that interests us today is the growth hormone. So it regulates growth, metabolism, and body composition. The secretion of growth hormone into the bloodstream stimulates the liver to produce another hormone called the IGF-1 or the insulin-like growth factor 1. And IGF-1 is what actually causes tissue growth in the body. So when we have a high level of growth hormone or a high level of IGF-1, bones increase in size, namely hands, feet, and face. So those physical changes occur gradually, so it's often not recognized immediately. So when acromegaly is not treated promptly, it can cause serious illness and it can even become life-threatening. There are several treatments who can reduce the risk of complications and improve the symptoms. The diagnosis is made by blood test and MRI scan. Blood test for abnormal growth hormone levels and high IGF-1 level, as we can see an example. An MRI scan to define and locate the size of the adenoma. So we have several treatments. Treatment number one is the surgery and or radiation therapy. And the medical treatment, we have the somatostatin analogs or the SSAs, the growth hormone receptor antagonist of bevacizumab, and the dopamine agonists. And the goal of the medicine treatment is to obtain a normal IGF-1 level in the blood. So the therapeutic indication of bevacizumab is an inadequate response to surgery and or radiation therapy. And when the SSAs did not normalize the IGF-1 concentrations or the SSAs were not tolerated. So bevacizumab has demonstrated efficacy in attaining an IGF-1 normalization. So starting a new medicine causes lots of questions, namely about the diagnosis, about the symptoms, about the complications and results. And a few of these questions are that people ask, what is bevacizumab? What are the possible side effects? How should I take it? What happens if I miss a dose and when I overdose? And what other drugs will affect bevacizumab? These are a few questions. So starting a new medicine means an obstacle in patients' lives. They need a daily subcutaneous injection, and who will learn them how to self-inject. Also, patients have great expectations when a new medicine has started. So all of these questions and comments were the start of a home care educational program. So when the doctor prescribes the medication, he has also to fill in a document, and this is sent to an institution, and in Belgium it is called the National Institute for Sickness and Disability insurance, and they agree or disagree, and afterwards the patient and the doctor, they get confirmation of this document, and then they can get Pegvisament. So when patients have the confirmation, they go to the pharmacy and they come home with a box full of material, as you can see here, the new medicine, the syringes, the needles, and the adapters. And they have always a supply for 1 month. So people are very unaware, they are not informed, and they don't know how to self-inject the Pegvisament, even when they follow the instructions on the prescription label. So that is why patients were trained for a daily subcutaneous injection at home by one single specialist nurse. The program is divided in 4 days of visits. It's a very important week, the first week, because people have to learn how to self-inject. Afterwards, from day 30, we have interview, phone calls, and visits when needed. So at day 1, we have a 2-hour visit, where I explain all about the disease of acromegaly, also the symptoms, the signs, and the complications. People get a small backpack. It is filled with 2 boxes, where they can store the Pegvisament, so they can put it in the fridge like this. When they travel, they can use the cooling elements. There are 2 of them inside a backpack, and there is 1 small one. So we also discuss the possible side effects, and very important, I show them how to manipulate all of the material with attention to sterility. So we practice mostly with the demo material. At the end of the session, I fill in the task list. And the task list is a patient-assessed acromegaly symptom questionnaire with 5 of the symptoms of acromegaly, namely headache, excessive sweating, joint pain, fatigue, and soft tissue swelling. So they need to give a number from 0 to 8, how severe the symptoms are. And this task list is a tool for the quality of life, so we can evaluate. On day 2, I mostly repeat what I said on day 1, and we practice with the demo material. So on day 1, I administer the injection, but from day 2, patients need to administer the injection by themselves. I also talk about the importance of adherence and about the dose titration. So when they go to the doctors and they give blood samples and they know afterwards what the level of the IGF-1 is, sometimes there is need to change the dose. So when there is a dose adjustment, I can explain all about it. So I made a list for the patients. This is a list, a little diary, small diary they have to fill in day by day. So they fill in the Pegvisament dose and afterwards the injection site, because sometimes they forget where the location was the day before. They can fill in the IGF-1 level. Patients, the acro patients with diabetes can also fill in the blood glucose level. And then they can always put some comments or questions. So when they see or hear me or when they go to the doctors, we can discuss all of this. Day 3, also an important day, because from day 4 they need to administer the injection by themselves without my guidance. So I repeat all the important things and we mostly practice. On day 7, I check the autonomy. So if they manipulate the material in the right way and if they administer the injection also in the right way. So we discuss also the importance of the adherence, the dose titration, and all the questions they have in that last week. Then from day 30, we have regular moments that I call the patients, interview phone calls or visits when needed. I ask them the questions of the PASC, the 5 questions, or when they need information about the dose titration, they can get it, or all the other questions they have. I try to answer them. The observational study, there was an evaluation of the home care program and the quality of life in 18 acromegaly patients upon start and during treatment of pegfisimant. As we can see, in all participants, the IGF-1 decreased, sometimes needing dose adjustment from 10 to 30 milligrams. And associated treatments were the long-acting SSAs. The results of the PASC list, the quality of life improved significantly over time based on decreased complaints of headache, perspiration, joint pain, fatigue, and soft tissue swelling. 2 adverse events were recorded. There was 1 hypoglycemic episode in an insulin-treated woman with type 2 diabetes and 1 case of lipodystrophy. So I decreased the units of the insulin, and nowadays this patient doesn't need the insulin anymore. She only gets the anti-diabetic oral medication. And the other case of lipodystrophy, we use the needles of 10 millimeters, and with this patient we had to use the longer needles, the 16 millimeters, so the problem of the lipodystrophy was solved. In the home care program, none of the patients discontinued pegfisimant, and there were no dropouts observed. So as I was telling you, I am going to tell you a patient story, so nothing speaks like experience. So this is Monique. She was born in 1953. We can see here a picture of age 7, at age 18, and at age 21. And further on at age 25. So at the age of 35, diabetes type 2 was diagnosed, and it was her GP who treated her with oral medication for about 20 years. So in the 90s, she suffered from a depression, and she got problems with hypertension and high level of cholesterol. So over time, several signs and symptoms, typically for acromegaly, became increasingly severe. So enlarged hands and feet, changes in the shape of her face, enlarged nose, thickened lips, wider space between the teeth, enlarged tongue, oily, thickened skin, excessive sweating, fatigue and muscle weakness, joint and limited joint mobility, headaches, and she became insulin dependent. So because acromegaly tends to progress slowly, early signs may not be rapidly apparent for several years. So people notice the condition only by comparing old photographs. So at the age of 56, she suffered from severe stomach pain, and she arrived in the ER in the University Hospital of Ghent. So they did blood tests, and her IGF level was seriously elevated. It was 1032. She also had an MRI scan of the brain to locate the size of the adenoma, and it was 15 millimeters. So it was necessary for her to treat her with medication, the SSA, and to have brain surgery. The IGF-1 level decreased, but not enough. It was between 200 and 300. So the endocrinologist decided to combine the SSA and daily pegfisimant injection. She was very accurate about her consultations in the hospital. So at the endocrinologist, at the neurosurgeon, giving blood samples, going to the MRI scan, no problem. But she was very ignorant about the disease acromegaly. She only knew how to self-inject insulin, but it stopped there. So all the arrangements were made for her to get the pegfisiment. She went to the pharmacy and she came home with a box full of needles, syringes, adapters, and the new medicine. So she was also very unaware. She didn't know how to start to give the self-injection. So that's where I came into the story. It was obvious that she needed information, that she needed guidance, teaching, and explanation. So on day 1, I explained to her all about the disease acromegaly, and I showed her how to manipulate all the material she would need. So the following days, we mostly practiced with the demo material, and I tried to answer all of her questions. So this is a picture with her dog, Rambo, and the other picture is one taken during the sessions. So she and the other patients were very happy with the home care educational program. So they had a feeling of relief and satisfaction. They were very grateful. They felt protected and very motivated. So I also want to say, don't underestimate the psychological, social, and emotional role in acromegaly. So conclusion, working with a specialist nurse may help to improve the quality of life by attaining rapid IGF-1 normalization. And the PASC scores improved both on short and longer term. So patients were very happy with the education, the information, and the training. They were very grateful. They also felt independent because they could self-inject the injection, so they didn't need a nurse every day at home. Also, when they were traveling, they could go on with the treatment. And when they saw the results, they were very motivated and stimulated. So as I said, don't underestimate the psychological, emotional role in acromegaly. Patients feel ashamed and shy the way they look like. They have little or no social contacts. They have feelings of loneliness, isolation, depression, and struggle. Acromegaly is a rare disease. It is not in the media like diabetes or cancer or the heart disease. So there is one acro patient, an American, Wayne Brown, who wrote a book about this, Alone in My Universe, and he wrote about his struggle with the disease acromegaly. So I stay in contact, in touch with all of the patients by phone calls or by visits. And we discuss the titration. I ask the questions of the PASC lists when they have problems with side effects or adverse events, and they can always ask questions when they need to. So they can always phone or text or email me when they have any questions. I also have a data bank with the IGF-1 levels. Also all the results of the PASC, the levels of the liver enzymes, and the blood glucose. So I can say the home care program is an improvement in satisfaction and adherence. It's very successful. We started in one center in the University Hospital of Ghent, and nowadays we have 9 centers all over Flanders, and it's still growing. So I just want to say my message. My message to you today was to tell you all about the need and the importance of the home care educational program. So thank you for your attention.